Patrice told me it was very important to the group that I talk about conditions associated with Syringomyelia because that's why a lot of you come to the conference. So if you have any questions, as I said, I have like 13 slides, so I should have plenty of time. All right, well, one condition associated with Kyary is Syringomyelia. It's about 1 out of 10,000 patients, and usually occurs in middle age or early, 20 to 50. Sometimes occurs in children, but it's a congenital lesion, and it's always been a question, why? Why now? Why would it develop most often at 20 to 50? Associated with the Chiari is basilar invagination, and that's, we can talk about that. And then some people have lesions not at the craniocervical junction, but in the spine, and about 12% of the people have that. And then there are other people who have intramedullary tumors or what's called myelitis, which is from multiple sclerosis. All right, so when we talk about, I don't really have the laser here, I should have thought ahead, I guess, but well, that's not the way to go. As you can see here, that's a cyst in the spinal canal, and there's a, oh, here we go. Here we go. Okay, I'm trainable. All right, so here's the spinal cord, here's a cyst, here's the spinal cord below, and that's what's called an arachnoid cyst. And this was a man, he worked in construction, and he had this cyst, it pressed on the spinal cord, and he developed Syringomyelia. So the underlying condition, this cyst, blocked the spinal fluid flow and caused the syrinx to form. So after taking out the cyst, the syrinx went away. So it's very important to know what's the primary condition, what's the secondary condition. The primary condition is what caused something to occur. So in this case, even though he came down to see me and he says, look, I want you to put a tube in my syrinx, I said, well, it's probably better to take away the thing that made the syrinx grow in the first place rather than treat what was the result of this thing pressing on the spinal cord. Because if you just put a tube in the syrinx, then you drain the syrinx, but you still have something pressing on the spinal cord, which can be a problem in and of itself. All right, Dr. Batzdorf is an expert in Syringomyelia and Kyary, and he came up with this algorithm. But anyways, you have this problem, a Kyary and syrinx, and the hindbrain is, these are the symptoms related to the Kyary, these are the symptoms related to the spinal problems like the syrinx. And so you just follow this down. If you have local pressure from your Kyary, that presses on the dura, which is the substance around, the membrane around your Kyary, and that gives you your occipital headache. If it presses on the neural elements, then that presses on the brainstem, and then you have visual problems, balance problems, hearing problems, sensation problems in your face, trouble, maybe some hoarseness talking, trouble swallowing. Valsalva headaches are very common with Kyary, and then loss of sensation, loss of movement in your hands, and autonomic sensations. That comes from the Kyary and syrinx symptoms. So everything's associated. Nothing occurs out of the vapor. Everything has a reason behind it. So for clinical signs and symptoms, you could say, well, I'm here for the associated conditions. But sometimes when people say that, they mean symptoms, because they've had treatment, and it's, hey, how come I still have treatment? I have symptoms because I've been treated. So most of the people that we've seen at the NIH have had headache, and it gets worse with coughing. At least that's before surgery. Some have pain, some have weakness, some have trouble walking, some have increased pain with cough. And then when we examine them, many are weak, some have loss of muscle strength, but these are patients with Syringomyelia. Most Kyary patients without Syringomyelia don't have atrophy. All right, so let's just get into some of the associated conditions and see if any of you have anything that's associated. All right. So you might have a condition that predisposes to Chiari malformation occurring. And some of those are related to brain pressure increases. I wasn't going to say, well, the brain is larger, but it really can't get larger because, if you're not and I don't think anybody meets this description, if you're not under 1 year of age, your head's not going to expand if your brain expands, so the pressure goes up. So if you have hydrocephalus or pseudotumor cerebri, you're more likely to get Chiari. If you have a small skull, say you have what's called cranial synostosis, and your soft spot closed a little bit too early, then you can get Chiari. If you have low spinal pressure, if you've had a spinal tap or a spinal drain or a spinal shunt, you can get Chiari. The low pressure sucks the tonsils down and you get a Chiari. If you have weak connective tissue, people don't really understand. Well, I don't understand. Some people must understand, but I don't understand completely how Ehlers-Danlos is related to Chiari. What we do know with Ehlers-Danlos, though, is if you have surgery, you don't do as well as people without Ehlers-Danlos. The way I think about this is you have weak connective tissue, you stand up, the dura expands, and it's just like you had a low spinal pressure syndrome. In other words, you get a dropping of the brain and into the spinal canal, at least the tonsils, and you get a Chiari. The other way to look at that, maybe the connective tissue in the brain allows it to sag more. So that's the connection with the Ehlers-Danlos. Chiari malformation might be associated with another condition that it's developing with, like basilar invagination or something that occurs the same developmental time in utero. So you get a basilar invagination, tethered cord syndrome. As I said, about probably 20 or 30% of the people with Chiari, symptomatic Chiari, will have Syringomyelia. And then you can just have, if you have a common condition, you can say, well, why do I have migraine with Chiari? Well, you might have migraine with Chiari because your mother had migraine, your grandmother had migraine, every relative you know has migraine, so you just have migraine. That's just, it's randomly associated. Other people who have headaches that are similar to migraine, there might be a relationship if they have high intracranial pressure. I've looked in the literature, and this is a theme, this untreated cranial synostosis. This is a theme in the literature, and you see articles like this. 15% of children operated for symptomatic Chiari 1 would have this untreated sagittal synostosis. That means that this suture here that allows your brain to expand and it allows the skull to expand, it closed too early. And those people have a little longer heads than the rest of us. And they're at risk of having Chiari. And the plastic surgeons have found that too. They had 5.8%, so not quite as high, but still a significant percentage. And if you have this suture closed too early, rather than having a risk of Chiari of 1%, it's 5%. So I think that in 5 or 10 years, that's going to be a big deal. That not all the Chiari surgery is going to be done in the back, but people will be expanding the skull. All right. As I said before, this can be associated with raised intracranial pressure. I talked to Dr. Iskandar. He thinks that with his research that people who've been shunted early in life have disorders of pressure, and that they might have a little. Their skull didn't expand it to its proper dimensions, and that they probably have problems with what's called compliance. And so even though they've been treated, they might be more likely to have problems with raised intracranial pressure. And some people with Chiari have increased intracranial pressure. So in this series that I looked at, and I have all these things referenced, 15%, so quite high. And If there's suspicion of that, you have to go to a neurosurgeon and they will monitor the intracranial pressure, and there are ways to reduce intracranial pressure. So even though you had a Kyary and it's treated or not treated, your symptoms might be from increased ICP and not from Kyary. All right, so I'm just the warm-up band for this. Petra is going to come later and tell you all about this, but this is what tethered cord is. There's just this, see, these are all nerve roots in the low back, and which one is not like the other? Okay, so these are nerve roots, and this, see the shiny thing? That's the phylum, and that's what is pulling down the spinal cord. And if you have that problem, if you cut that, that can improve symptoms of tethered cord. And the symptoms of tethered cord are back pain and stiffness of the back and neurogenic bladder. So if you have urinary retention, if you have a lot of back pain, if you have trouble bending over because your back is really stiff, you might have tethered cord syndrome. All right, well, Chiari can be related to scoliosis, and it doesn't seem like it's associated with Chiari 1 malformation alone. It seems like you have to have Chiari 1 malformation, which causes Syringomyelia, which causes scoliosis. So if somebody has Chiari 1 malformation, Syringomyelia, you treat that. Sometimes that reverses or stops the progression of scoliosis. So what's the risk of that? Here's 259 people with adolescent idiopathic scoliosis. About 4.2% of the people out of 259 had Chiari 1 malformation. 5% had Syringomyelia. All right. A lot of these things, even though they're associated, I thought the group would be interested because they're really symptoms. They're not conditions, but headache, ataxia, which is poor balance, hoarseness, trouble swallowing, sleep apnea, the central type, not the obstructive type in the throat. And then syrinx, the cardinal or the most common things are pain, weakness, and spasticity in the legs. Paulo talked about this cervical medullary syndrome. And Dr. Henderson has great interest in this, and he did a study. And if you have this, and this is really, you have a connective tissue disorder, and you have too much angle at the base of the skull, so the medulla is being compressed. And in those cases, sometimes a fusion, which is not a trivial procedure. But if you had these non-trivial problems like imbalance, trouble swallowing, dizziness, memory problems, walking problems. It's a non-trivial operation, but it should be done for people with significant neurological problems. Psychiatric problems. Okay. If you're a child and you're between 6 and 17, well, first of all, you're probably in another room if you are, so I assume that this probably applies to adults, but I don't have the numbers. ADHD, 22.1%, anxiety, 12.8%, depression, 10.5%. And this is from the Chicago group, and here's the reference. So there are increased rates of psychiatric problems, and many of these can be related to the stress of the condition, not feeling well, but some of them might somehow otherwise be related. All right, if you've had surgery, what else can be associated? You can have a CSF leak, a pseudomeningocele, aseptic meningitis, which is just meningitis without bacteria, or hydrocephalus. And we always check for spinal instability. Some people need a fusion after a Chiari operation if you have instability. Okay. What headaches are Chiari headaches and what aren't? There's a criteria. to try to differentiate the two. I think at this meeting there will be somebody who will talk about that, so I won't go into it for very long, but most of them are occipital, which is the back of the head, and made worse by coughing or Valsalva. All right. And then the only other thing I wanted to point out is somebody asked about Kyary and Syringomyelia and Myelia presentation after trauma. And Tom Millerot, who probably had the largest series, thought it was about 15%. About 15% of the patients would present. Now, Chiari's considered a congenital lesion, so you've had it your whole life, but the trauma can just make it develop earlier. You can develop symptoms earlier because of the trauma. So, even though most people present with symptoms from Kyary, one malformation, between 20 and 50, maybe the auto accident brought it on a little bit earlier, or maybe they never would have had that. So that is a common question, but Dr. Millerot just looked at the statistics from a clinical standpoint, not from a medical legal standpoint, and that's what he came up with. So I said I'd finish early. If anybody has any questions, I'd be glad to answer them.